we're kind of just going to open this to you guys. Both of us are here to answer any questions you might have. And we're also happy to go over any kind of new data or any of the studies that you might have more questions about. So just let us know. Yeah.
The last thing that I wrote down was immunotherapy predictors.
Yeah.
I'm frantically writing notes, and I'm like, I need to know more about that. So, you know, that when you CAR T predictor.
Yeah. There is different models that can be utilized to predict.
Yeah, you're stuck.
I'm stuck with this, aren't I? Okay. There are different models that can be used to predict the risk of developing kind of toxicity to the CAR T, as well as like the risk perhaps maybe that the treatment might not work as well. And then some of those models are more adjusted for like the safety part and some for the efficacy, but then most of them appear to like appeal or work for both. So one of the very simple scores I went over, it's called the CAR hematotox, and really all we do is we look at your blood count. So we look at the white count or the absolute neutrophil count, we look at the hemoglobin and the platelets, and then we look at the inflammatory markers, the ferritin and the CRP. Those are just inflammation markers. And if that score is 2 or higher, it tends to predict for kind of more toxicity and less response. And a lot of it also predicts like how long will you have low blood counts. So the patients who have a higher score might have longer lasting cytopenias is what we call them, or low blood counts, and might need more support, like a stem cell boost where we give, for example, we store some cells after transplant and we give these as a boost to help raise the blood counts. Beyond this is kind of very simple, easy to do for us. There's other risk scores that might be a little bit more complicated and involve like genetic risk factors, and that there's some new projects looking at like AI and how you can model some of this, taking into account everything, but I think a lot of those are kind of in development.
Is this being done just for CAR T, or is it for all, this
Yeah.
charting?
That's a great question. Do you want to speak to that? Like by specific?
Well, the reality is that, this is loud. CAR T and bispecifics.
What was the question?
The predictors.
Do these predictors that Dr. Hansen was mentioning apply to other therapies? And our experience with CAR T and bispecifics they go hand in hand, in essence. These novel therapies, they share a lot of qualities, right? And also side effects, right? With bispecifics, you will encounter a similar toxicity profile in terms of CRS, infections rates, neurotoxicities, ICANS. There are some others that are more specific to a particular product per se. So we do share kind of the same predictors to some extent, the inflammatory markers, the counts of the patients. As Dr. Hansen was just mentioning, in the future, we have some projects exploring AI. You know, AI is taking over the world. We're just waiting for Sarah Connor to show up with the Terminator. But yeah, in reality, it's gonna be a great tool for us to not only predict side effects, but also responses, right? Because we want to make sure that the product that we give you is the one that is going to give you the best chance of success, right? We do not have currently that crystal ball to tell you, hey, Mrs. X, you are going to do great on this product. Although at Moffitt, we do have a mathematical calculator called EMA that does help us based on the tissue and the type of cells that you're manifesting, essentially, what type of drug has the better chance of getting that better and deep response. It's a predictor, right? It's not a guaranteed, but it does help us sometimes use it. But that EMA, for example, it's just used at Moffitt right now and for some patients, and it's an investigational tool. Hopefully in the future we'll have better tools at our disposal to guide your therapy, because like I said earlier, myeloma is not a one-size-fits-all, right? Every myeloma is different in the biology, the clinical manifestations, the responses, everything is different.
Are more than one Moffitt, you guys are doing it? I'm assuming most of the research locations are using some type of tool as well.
Absolutely.
Okay.
Absolutely.
All right, I'll let everybody else ask questions, sorry.
That's a good question.
Thank you for so good presentations. I learn a lot always on this. So here is the situation. I was diagnosed in 2020, and because it was COVID, after getting ready for ASCT, I just was thinking I'm going to bypass this because I'm scared that I'm not going to have good immune system after this too. So as a result, I have my stem cells harvested and stored. So this is one question. Maybe you can tell me if some place on the road I have problem with exhaustion of my, bone marrow producing cells, if I can be helped with this. And then about CAR-T, it was great presentation, and I saw with pleasure that there are another CAR-T coming, because I suspect that for me the neurological problems can be bigger. Why? Because recently I developed the tremor of the hand, and I was thinking that this is a result of Revlimid, that I am on maintenance. But I went to neurologist, and they did special brain scan, and they discovered that I have Parkinson. So right now, do I understand correctly, if I'm going to relapse, the existing CAR-T are dangerous for me, and is Emma going to predict this? How I can develop this theory for myself, like how I defend myself so I can take the best use of existing drugs. That there is a lot of things going on, and we are so fortunate, and we thank you guys, that you work so hard developing the new ones.
Those are great questions. Thank you. Yeah, no, thank you. I mean, when we present a lot of these studies, you assume that everything is perfect, right? Everything kind of looks perfect on the outside. But what we know is, when in real life, right, when we see each other in clinic, there's no such thing as perfect. There's always going to be some type of, somebody might have the kidney function might be high. Somebody might have Parkinson's or other, heart issues or whatever, lots of different things can come up. And I'm glad you brought this up. So I think you had two questions. I'm going to start with the first one. I am so happy that even if you didn't do the transplant, that you were able to get your cells harvested. I can't stress how important that is, because as we have, these newer treatments like these new CAR-Ts and even bispecifics, a lot of them can suppress your immune system and can lead to low blood counts that can take some time to recover. Majority of our patients might recover their blood counts by about 3 months after the treatment, but you still have about 20% that might linger on. The blood counts might be longer or lower over a prolonged period of time. And sometimes folks can develop, repeated infections or complications. So being able to know that you have stem cells stored, generally their viability is very good, they last for a long time. You're right. Yes, we can use what's called a stem cell boost. And without any need for any kind of chemotherapy, it's just an infusion where we give these cells back to you. And generally speaking, it works quite well. The patients do recover their blood counts, and it helps kind of restore your immune system somewhat. And we've seen it work very well post-CAR-T, generally speaking. So glad to hear you have those cells, and we might very well use them down the road. Now, your other question regarding Parkinson's and CAR-T, it's a great question, right? We have, as I mentioned, we have two CAR-T products. We have Abecma, we have Carvykti. Carvykti is the one we're using more and more because of the efficacy signals. It just appears to work a little better. But the question is, it does have side effects. And as we're using it earlier, where we have less disease, the rate of Parkinsonism as a side effect is declining. So for people who got this Carvykti later, like in 4th line or beyond, the rate of developing Parkinsonism, the incidence was 6%. Now that patients are getting Carvykti in 2nd and 3rd line, that rate is less than 1%. It was 1 patient out of 200 on the clinical trial. So the incidence is less if you get it early. Nonetheless, it's still there, right? You can still develop it or it can worsen, and it's very difficult to treat. And beyond Parkinsonism, there's other neurologic things like Bell's palsy that we have to take into account and other nerve palsies. With that being said, you're right. I would be a little bit nervous to give you Carvykti because I don't want your Parkinson's to get worse and out of control. I don't have the answer because we've never treated Parkinson patient with this type of product, but you're lucky in the sense that anitocaptogene or anito-cel is likely going to be FDA approved in 2026. I think they're looking to file to the FDA at the end of December, is my understanding. So, and that one so far, there's no risk of neurologic toxicities. They have not seen any of any sort, including Parkinsonism. And then we also have clinical trials, and hopefully these products will come down the pipeline. One of them is AstraZeneca, where it's a dual targeted CAR T. It's with BCMA, but on the phase 1 study, they did not see any of these neurologic toxicities. So hopefully that will be coming down the pipeline as well. So I think there is hope and there are things that we can do. But I think beyond CAR T, there are bispecifics, right? And the risk of getting these with bispecifics is much less or not there. And I'll let Dr. G speak to that.
Yeah, I want to piggyback on those 2 questions, and I echo Doris. Great questions, number 1. Number 2, thank you for sharing your journey, right? We really appreciate that. The first topic was I want to touch a little bit about the transplant, because although it was not your question, it's always a recurring question. If I have my cell store and what I'm doing right now fails, would it be reasonable to transplantation? Right? This delayed transplant, can it be considered? There is no right or wrong answer, right? But we know that delayed transplant is not as good as early transplant, right? And the second part of it is, if I do a transplant once, can I do a second one? Because we always collect and store for 2, in essence, right? We have some extra cells for the most part. The answer is, well, it all depends what kind of responses you get from the first transplant, right? Because statistically speaking, the second will give you half of it. So if you get a run of 10 years, great, you can expect 5 years from the second. But if your response is only 3 years, does it make sense to go through the loops and hoops of transplantation just for a year and a half? Maybe not, especially given the fact that we have such great therapies nowadays to get you out of trouble. And the most important part, in my opinion, is the risks, right? Because melphalan, like I said earlier, is a dumb drug. And so it has side effects on the long run, including secondary cancers like MDS and leukemia. And there's a cumulative effect, right? The more melphalan you get, the higher the risk of those. So I'm always very cautious about these second transplantations and whatnot, and that practice is kind of fading away a little bit. To the later point in terms of what about CAR T in the setting of Parkinson's disease? And I have to echo 100% what Dr. Hansen said. I'll be a little bit more nervous about that scenario. That is possibly the best scenario for clinical trials. And as a matter of fact, we have at Moffitt CAR T trials that could be a great option, right? Targeting something different like GPRC5D, right?
Interesting, doctor. Sorry that I interrupt you because I thought that now I'm excluded from the study.
For that, yes. But patients that, what I'm trying to say is that we have other targets that are coming in the horizon, right? With different products. And GPRC5D, which is what one of our colleagues from the University of Miami was mentioning, talquetamab. Talquetamab has significant side effects, right, in terms of oral toxicities. However, the GPRC5D CAR T does not seem to have as bad of a toxicity, right? And we're going to sound like a broken record. The big benefit from CAR T, you do it once and then you watch. And that treatment-free interval, to me, is the most coveted, aspect of your journey, right? Because you don't want to be seeing me and treating you all the time. Sure, bispecifics are there to help you, and most definitely, I would favor bispecifics for you, and we have nowadays two that are available, teclistamab and elranatamab, and they do not have this Parkinsonism that it's been seen by cilta-cel. So you have options, and that is just thinking about the novel therapies. Other combinations over triplets, you have an ample palette of options for you with CD38s, PIs, and IMiDs combination, depending of the clinical trial that you want to use. You could do DKD, ISA-KDEX, DPD, ISA-PD, ELO in any combination, etc. So you have a lot of options ahead of you, okay, that are not necessarily CAR-T. So don't think that because you have Parkinson's, your options are extremely limited. They're not, okay? You have other alternatives at your disposal.
Thank you. And I'm fortunate that I'm in Moffitt, I guess, because you guys are great.
So I had a question regarding treatment options. Just to give you a quick summary of my story, I was diagnosed in 2022 with a high-risk smoldering. I enrolled in a clinical trial with isatuximab, the lenalidomide, and the dexamethasone. I'm through with that clinical trial. I just finished last month, the 36 cycle trial. I guess right now we're monitoring to see how that's. I had a response to that. It wasn't as deep as I would have wanted it, you know. But again, that's just my personal opinion. My question really is, moving forward, depending on the monitoring of my situation now, is there currently a system in place or through AI that you can input your biology and the predictors on toxicity of different treatment options that could best guide you to when and if the time comes and I need to look at another option, another treatment option? Is there something to that effect that I can, give? There's so many options now with the inductions of 2, 3, 4 medications, as opposed to maybe a bispecific CAR T-cell treatment. Is there something that could guide me a little better, as opposed to, it seems like now you just throw a dart, Yes, that's correct.
So let's take it one step back, right? Because high-risk smoldering is one of those challenging pictures, right? Because although technically, like I said, it's not necessarily an active cancer, it's about to, right? And that's why I always encourage patients in your scenario to participate on those clinical trials. Historically, these clinical trials have, to some extent, changed partially the natural course of the disease. And I say partially because if you look at QueerDex, RevDex versus observation, most recently Aquila, DARA versus observation, sure, there is a benefit in time to progression, time to next treatment, PFS, or the remission time, and even overall survival. But it's not a cure. So we're basically kicking the bucket down the lane. And that is kind of the criticisms that we sometimes had for these type of studies, right? Because it doesn't really truly offer a dramatic benefit to the patient. Because ultimately what we want is to stop the cancer from even starting completely, not delaying it necessarily, right? That's kind of a partial answer to my taste. Now, the Revive trial, for example, trials like the ones that they're having at Dana-Farber with CAR-T in smoldering, those are potentially more significant trials in my opinion. And why do I say that? Because historically, if you look at the single-agent activity for Revlimid, DARA, isatuximab, all of them, the overall response rate for those, we're talking about 30%. That's why we have these combination therapies, right? If you look at all the novel therapies, from bispecifics to CAR-T, all of them consistently have an overall response rate, single-agent activity in the later relapses of 70% plus. Cilta is 90% almost, right? So if you look at the as-treated population on that CAR-T4 trial. So these therapies have a better potential of getting truly rid of the brunt of the disease. Like you said, your response might have not been as excited as you expected with this ISA-REV combination of the trial. But it's not necessarily a bad thing, because the fact that you brought your numbers down, even though they're not stone cold normal, that doesn't necessarily mean that your myeloma is going to get active tomorrow or the day after, right? Because the behavior of it, it's really, really unpredictable, if you want to look at it that way. We don't have the crystal ball. And to that question, do we have any predictors right now that are standard of care to help us determine whether or not you're going to progress soon? No, we don't, right? Emma, for example, the one that I was referring to, we rarely, we'll never use it in that scenario, for instance, number one. Number two, not even for early relapses we use it. We use it more for later relapses because it's a costly test for sure. So we're a little bit more diligent at selecting the patient for that. And the fact that you got ISA-REV at the beginning, your tumor microenvironment could have changed, but it doesn't necessarily say that you're not gonna react great to whatever therapy if you ever need it. If and when, those are the two operative words. And I just want to clarify something. In the first line setting, 2 drugs are not enough. 3 drugs might not be enough. 4 drugs should be the answer if you can tolerate them. And we have, I showed the data already, right? We know that those 4 drugs, when compared to 3 drugs, and most definitely 2 drugs, you will have a better outcome. So always 4 drugs.
So what's your opinion, as opposed to a 4-drug or 3-drug induction to they're having some current clinical trials on the bispecific T cell for smoldering, you know? What's your opinion on that? And do you have any data input on those trials that have been ongoing? I know at the University of Miami they've been doing it, and I'm kind of leaning towards that, or I want to get more information on these bispecific T cell. Is that a combination of T cell and bispecific that they?
Correct. So number one, I'm biased. My answer will be trial, right? So because that's how we move the needle. Number one, regarding that trial, yes, it's a combination of Dara-Tec or Dara-Tal. The results, we don't have them yet. We won't have them for a long time, because in myeloma, like I told you, we have a really good problem to have, and is that you guys are living too long for clinical trial purposes, and to get to this endpoint, it takes forever. If you look at even Ascent trial that we had at Moffitt, that curve looks almost horizontal. By the time that we get to that endpoint, it's going to take a long time. But we always encourage you guys to participate on those trials, especially with novel therapies. So absolutely, I would applaud the decision of, knocking on that door.
Even when my numbers change or I need that. Now, the fact that I took this other clinical trial, does that preclude me from, or that you just go through a washout period?
Yeah.
If that gets to that point.
Yeah, I agree with everything that you've said. Just to add a couple of things, are they watching your MRD? Like, are you MRD negative? Do you know anything about that?
Negative.
Okay.
Either I've had 4 different bone biopsies. I'm getting another one on the 30th. That was part of the clinical trial, throughout the course. And no, I'm not MRD negative.
But you just finished, right? You just finished the 36 months.
Last month.
Okay.
Was my last.
And what type of response did you get?
Okay, I went, my M spike was 3.6 when I got diagnosed. It got as low as 0.9. I'm at 1.2 now. I'm kind of bouncing there. I've been bouncing there for like 3 or 4 months. I'm on Kappa light chain and IgG hemoglobin. Those are my characteristics of mine. And those numbers have been, they've gone down significantly from what I started with, but I've been bouncing. I just kind of want to plan for what and if something comes next. What are my best choices? How do I die? Because there's just so many options out there, so many different combinations of things. I'd like to kind of narrow it down to something that's best for my situation, my biology.
mean, as I understand it, I think with smoldering disease, like high-risk smoldering disease, the goal is like we don't want you to, let's say, get kidney failure or get, bone lesions, or you might have a fracture that might really like impair and affect your quality of life, right? So treating the high risk, those are the things we're trying to achieve. I think, getting the treatment looks good. It seems like you just finished it. So giving it a little bit more time to see, is the response going to deepen, how things will look down the line. With smoldering, I think certainly doing a bispecific trial is very reasonable. Just to speak a little bit more to the Dana-Farber like CAR T study, the cell-to-cell, very few patients, but basically everybody responded, everybody got MRD negative. The issue there is that there still saw like Bell's palsy in the study, even in the early line, but it did resolve. So I mean, I think that's a consideration. There's also some new data at ASH that Dr. Costa also presented where, if we watch MRD, should that guide, if we should do more treatment or not? Because right now we look at progression by, does your M spike rise? How does everything else look? We don't really use MRD to necessarily like start a new treatment. So I think while not yet, that's not the case, but I think future looking, right, forward looking, I think monitoring MRD status and perhaps, starting to act a little bit earlier might be the case. It's not now. I think there's work we need to do, but I think with high risk disease that hasn't gotten like a complete response, still MRD negative, I most definitely would consider, a clinical trial if available.
Well, it seems like that's the best world to be in under.
Yeah.
Like meet standards of care and FDA, requirements and all. And, that whole thing about precursor, excuse me for not agreeing with you guys. I understand what you want to say, but a precursor is saying I'm a little bit pregnant.
A little bit, not all.
Right. I consider if you got MGUS, you got cancer, but it's just a question of when and if you. So it's kind of hard to live with that wait and see attitude.
Yes.
That's something I couldn't deal with. So I needed to get involved in that clinical trial.
No, that's a great question.
And that is actually a very personal journey, right? Because that is absolutely subjective. You mentioned it. For you, it doesn't. The watch and wait doesn't really work, right? And that's not to get political, but your body, your choice. You get to dictate what it's done in the course of your disease, right? So there are some patients that want to be more proactive than reactive, others want to be more reactive than proactive, and there is no right or wrong answer. As long as you're comfortable with your decisions, that's the right attitude, for sure.
Dr. Gonzalez, my name is Jim. I have a follow-up question on your answer about your statement that second time through stem cell transplant is get half the result as the first. My understanding that the stem cell transplant is not what actually kills the cancer. It's the melphalan or the high-dose chemo. So the 50% efficacy of the second time, is that just because the disease has progressed, the body's immune system is weaker? That's a primary contributor to the 50% efficacy the second time through, or?
That's a great question. I think as myeloma is smart, or any of these cancers are smart, because with every line of therapy, the disease learns to kind of resist the drugs and it develops kind of mutations or mechanisms to just overcome the effect of the drug, if you might say. So I think, let's say if the first time, might have gotten a good response, now the myeloma cells are kind of wiser, older, they've learned how to avert your immune system, and they've learned how to work around these drugs. So it's just that the disease is complex, it's changing, it's becoming more aggressive, and it's not going to respond as well. And you're right, your immune system might be weaker, but quite frankly, I personally think that a second transplant is not really going to be very beneficial. Very, very rarely do I ever recommend a second transplant to my patients. There might be very few exceptions. If my patients had, I don't know, somewhere between 5 to 10 years of benefit, I might say, we'll consider it. But as you said, right, what's doing the work for the transplant is the melphalan. And melphalan is a very difficult drug. I'm sure some of you guys have had it. It's a very difficult drug to tolerate. You know, it has terrible GI toxicity. You're going to lose your hair. The risk of secondary cancers like leukemia is 5 to 7%. That's not negligible, right? I mean, you got terrible GI toxicity. You can get terrible infections. The risk of secondary cancers is not negligent. I will not put somebody through that again for little benefit when I have such good drugs at my disposal, like the new immunotherapies that work better, don't have the same side effects. And quite frankly, I know transplant is an oldie and a goodie. I'm a transplanter. I shouldn't be saying this, but we have that study that Dr. Grajales spoke about, is CARTITUDE-6. And actually, we're going to have another CAR T study in the newly diagnosed setting coming up at Moffitt from AstraZeneca. But, this CARTITUDE-6 study, because a lot of times, I get a question from my patient, like, I want to do CAR T, I don't want to do a transplant, or should I do one or the other? And this study, this clinical trial, really the way that it's working is like you get your chemo, the Darzalex with Revlimid, Velcade, and Dex, and then you get randomized. You either get CAR T or you get a transplant. So this study is really going to tell us, is CAR T better or is a transplant better? And should this change our practice or our standard of care? It's worked. Obviously, it's been around for a long time. I generally do not offer it as a second option unless I have a really good reason to do it. And quite frankly, if you did a second transplant, we might get into trouble in the sense that when you collected stem cells for your first transplant, we collected more so we can store them. So let's say now you use these and you're not going to get as good a benefit. Well, what am I going to do after CAR T when your blood counts are low and you're getting a lot of infections? I have nothing stored. So a consideration, right? These are decisions that we make with your doctor, with your provider. I personally would rather store those cells because I know most patients are going to get CAR T, are going to get bispecifics and new therapies. I'd rather store those stem cells and keep them in my back pocket for later use if I were to need them.
Great, thank you.
Yeah.
And just a quick comment on CAR T. I did the anito-cel study at Moffitt.
Did you?
Year ago, February, still in remission.
Congratulations.
I'm thinking it may be another year before I relapse. And Dr. Grajales, to your comment about one and done, I tell folks who ask, I'm on vacation from cancer. I'm getting blood tests once a quarter, bone marrow biopsies every 6 months. I'm actually a little disappointed about that because I love propofol. It's the best sleep I get. And now that it's every 6 months, I have to wait every 6 months to get a good night's sleep, but it's great. So the one and done is just awesome. When it relapses, I'll go into something else. I'll have, maybe another CAR T, maybe back on a chemo, maybe bispecifics, whatever it is. I'll be going back to my old friends at the community clinic more often, that kind of thing. But for now, on vacation from cancer, it's great.
Congratulations. That's amazing. Yay. One of my patients says that she also has had CAR T, not anito-cel. She got cilta-cel, and she says, I am a cancer thriver. She's almost 3 years out, doing incredible. Blood counts are good, has really done very well, just like you. So I think, yes, the one and done approach is quite nice in the sense that it might give you time and I feel like quality of life, even studies have shown, is significantly better. It might dip a little bit during that acute period within the first 30 days, but it should improve after. The data for anito-cel looks quite incredible, right? We're going to get an update here. I just learned yesterday at EHA, which is the European Hematology Association in Milan in June, with all patients included, because the update we had at ASH was with less patients. And I'd just like to see, longer follow-up, and we'd like to see the results of that study come out, but I think it will get FDA approved in 2026. But to your particular case, there's plenty of options that you have. We did just open, we have several CAR T studies. We have dual targeted CAR Ts, two of them, two separate ones. We have the GPRC5D study. We have bispecifics. So a lot of options, but congratulations. That's incredible. This is what makes our job so worth it when you hear things.
No, and we also have bispecifics combinations with other novel therapies.
Yeah.
Mhm.
Right.
I'm
Like,
taking bids, by the way, from different oncologists at Moffitt as to which therapy next.
good. No, that's great. And
Tayu says, let's do another CAR T. Rashid says, maybe by
Is Tyga your doctor, your CAR T
Yeah.
doctor?
Yeah.
Oh,
Oh,
okay.
he's
but
great.
but in
He's
reality,
they're
these
both wonderful.
Yeah, they are.
Yeah, absolutely. We have a teclistamab and iberdomide combination that would be a great option for patients that relapse after CAR T as well, right? Iberdomide is not a medication that is just yet FDA approved. It's a cell mod that is under investigation. Let's call it Revlimid on steroids, right? And so it's very promising. And again, we always encourage you guys, and we appreciate the willingness to participate on clinical trials because, again, we're good looking, but it's not what changed myeloma, right? It's the trials that did that. So thank you.
I'm sorry, Mary Lou, man, just real quick. So, just if anybody has hesitancy about clinical trials, my wife died of a very rare cancer, 2.5-year battle, uveal melanoma of the eye, the pigmentation cells in the eye. No standard of care. And it's so rare that they don't think they'll have a population be able to study it to develop a standard of care for probably 2 or 3 decades because the collection of data is so small. All of her treatment was clinical trial. And I can tell you, it was all wonderful. Not at Moffitt, because Moffitt didn't do that cancer. We were going to Pittsburgh, to Philadelphia, to England, 2 different centers in Miami, to Houston, just wherever we could find a trial to treat her. And the wonderful thing about clinical trials is the measurement and the monitoring is so intense. They collect so much more data, you get so much more information, and if you can talk these folks who are not allowed to speak much about data that's not published and public, you get to read and understand what they're really saying with the latest data that is not public to know how it's going and kind of what you get some glimpses into the future before they're allowed to legally talk about it and state definitively what's coming. So I'm a huge fan of clinical trials. I mean, I'll take standard of care every day if that's the best option for me. But if anybody has any hesitancy about clinical trials, from my wife's experience and my experience, go for it. Go for it. End of soapbox. Mary Lou, I'm sorry.
No problem. I had a BECMA and unfortunately relapsed in 11 months. So I have 2 questions. The first question is, what's going on with maintenance after CAR T? Are we studying this? Is there anything in the pipeline? After I relapsed, I was in a study for TEC and DARA, and I was in remission within a month. Worked great. I was on it for 18 months. A lot of infections was the issue. Took a year off before my numbers started creeping up again. So I am presently back on TEC, and we're going to add DARA again the second cycle. The question about the maintenance, and then the question about why is DARA not covered with TEC by insurance?
Well, I'll speak to the maintenance. I'll let Dr. G weigh in as well. But you're right. The reason why we didn't do maintenance, the studies that led to the approvals were like phase 2 studies, right? So clinical trials are wonderful, but they're very restrictive. And, you first have to show, is the drug safe, one? And then does the drug work well by itself before you can combine it with other things? So as you know, these CAR T therapies are very complicated. The way they were studied in the phase 2 trials, there were like single drugs being used to look at efficacy. Now, are there studies looking at maintenance? Yes, there are. There are studies with, for example, Revlimid combinations. We actually have a study for patients. This is post-Carvykti, not a BECMA, but for those who have high-risk disease, actually with a bispecific, elranatamab. So also, for higher risk patients where you might consider the maintenance. But a lot of the studies that are coming down the pipeline, generally speaking these days, are including more maintenance therapies, which is encouraging. In terms of why DARA isn't covered is because it hasn't been approved that way quite yet in that combination. But I'll let Dr. G weigh in some more about it.
So just to piggyback on Dr. Hansen's answer, yes, unfortunately the approvals that come from the FDA are based on the pivotal trials that were done, right? So if the phase 1, phase 2 study, or even the phase 3, if we're doing a randomization, is based on monotherapy, that's what the FDA is going to approve, right? And that, the perfect example is Abecma and cilta-cel. The trial for Abecma was done after 2 lines of therapies. The trial for cilta-cel was done after 1 line of therapy, right? So that's why cilta-cel got 2nd line and Abecma 3rd line. It's not whether or not we want to give a patient something. It's what question did we ask for the clinical trial? Now, sometimes we can make the argument to the insurance company for that product to be paid based on the studies that are ongoing, right? And even we have instances in which we combine teclistamab with even talquetamab, right? Because we have the data from Redirect that has shown very strong positive results, especially in patients with extramedullary disease. So it all comes down to what type of justification can we make to get the product paid for. But it's very possible that in the future, the combination therapies for these bispecifics are going to be the answer. Like I said, and like Dr. Hansen was also mentioning earlier, myeloma is a very fluid situation, right? It gets smarter. It's just a matter of us getting a little bit smarter than the disease when the time comes. And that clonal evolution, we have to make our best effort to minimize the timing of it, right? So those combination therapies are going to be the case. And we have done, I've treated patients with LRA-POM, TEC-POM. We sometimes introduce drugs that the patient has not been exposed to, or even if they have been exposed to, the combinations can kind of negate the refractoriness to that, because what we want to do with DARA and IMiDs like POM or Revlimid is to stimulate those T cells, right, to get a better response.
Yeah, sometimes I've actually, a lot of times we might have to appeal to the insurance companies. I've had a colleague of mine from Cleveland Clinic, we had to write a letter stating, myself and somebody else stating, like, we do believe that this combination is going to be helpful and you should approve it. So a lot of times we might have to talk to them about why we think that combination is appropriate. Yeah. So I think sometimes we need a little bit of kind of like experts agreeing and writing to them. I'm not saying that's a guarantee, but a lot of times it might work.
Yeah, okay, thank you so much. Unfortunately, we're out of time, but